Bradycardia is the medical term for a slow heart rate. For most adults, a heart rate below 60 beats per minute is considered bradycardia. However, this is not always a cause for alarm. The number on the monitor is only one part of a much larger story. Many people, particularly those who are physically fit, have a naturally slow heart rate because their heart muscle is so efficient. For them, a rate in the 50s or even 40s can be completely normal, just a sign of excellent cardiovascular health. It's really their body's way of saying it doesn't need to work as hard to pump blood effectively throughout the body, a testament to their conditioning and strength. The real concern arises when a slow heart rate is not enough to meet the body's demands for oxygen-rich blood. This is when bradycardia becomes a problem. When the heart beats too slowly, it can fail to circulate blood effectively to vital organs like the brain, lungs, and kidneys. This deprivation can lead to a cascade of serious symptoms and, if left unaddressed, can progress to life-threatening conditions. The key is to look beyond the number and focus on the patient. We must ask ourselves, is the body getting the blood flow it needs to function properly, or is this slow rhythm causing a dangerous decline in perfusion? So, how do we distinguish between benign or harmless bradycardia and a dangerous symptomatic one? The answer lies entirely in the patient's clinical presentation. We look for signs that the body is struggling. Are they alert and comfortable, or do they appear pale, sweaty, and distressed? Are they complaining of any symptoms, or do they feel perfectly fine? This distinction is the most critical first step in management. A slow heart rate in a marathon runner who feels great is a physiological marvel. That same heart rate in an elderly person who is dizzy and confused is a medical emergency that demands immediate attention and intervention. Therefore, the initial approach is not to treat the number but to treat the patient. We must assess for signs of instability, which are clear indicators that the slow heart rate is causing significant problems. These symptoms are the body's alarm bells, signaling that major organs are not receiving adequate blood flow. Ignoring these signs can lead to worsening shock, organ damage, and eventually cardiac arrest. Understanding this fundamental concept, that symptoms, not the rate itself, dictate the need for treatment, is paramount for anyone responding to a person with a slow heart rate. It is the foundation of safe and effective care. When faced with a patient with a slow heart rate, our first priority is a rapid and systematic assessment. We start with the basics, often referred to as the ABCs: airway, breathing, and circulation. Is the patient's airway open and clear? Are they breathing adequately? And what is their oxygen saturation? We immediately apply oxygen if they are short of breath or if their oxygen levels are low. This simple step can sometimes be enough to help the heart, as a lack of oxygen can be a primary cause of a slowing heart rate. This initial check gives us a quick vital snapshot of their immediate life threats. Next, we move to establish monitoring and access. It's really crucial to get the patient connected to a cardiac monitor to see the heart's electrical rhythm, a blood pressure cuff to check for hypotension, and a pulse oximeter for continuous oxygen monitoring. At the same time, we work to establish intravenous or IV access. This IV line is our lifeline, providing a direct route to administer fluids and life-saving medications if they become necessary. We might also check a blood glucose level, as low blood sugar can sometimes mimic the symptoms of instability and is easily corrected. These steps should happen quickly and simultaneously, preparing us for whatever comes next. The central question we must answer is this: is the bradycardia causing the patient to be unstable? We look for specific, serious signs. These include hypotension, where the systolic blood pressure drops below 90 millimeters of mercury, indicating poor perfusion. We ask about chest pain or discomfort, which could signal the heart muscle itself is not getting enough oxygen. We look for signs of shock, such as pale, cool, clammy skin. Altered mental status, ranging from confusion and agitation to lethargy or unresponsiveness, is another critical red flag, suggesting the brain is not receiving sufficient blood flow. Shortness of breath also points to cardiac and pulmonary distress. The presence of any one of these symptoms in a patient with a slow heart rate confirms that they are unstable and require immediate treatment. It is a clear signal that the bradycardia is the cause of their problems, not just an incidental finding. This decision-making process is a crucial fork in the road. If the patient is stable with no concerning symptoms, we can afford to monitor them closely and investigate the underlying cause more deliberately. But if they are unstable, time is really of the essence. We must act decisively to increase their heart rate and restore adequate circulation before irreversible damage occurs. Once we have identified unstable bradycardia in an adult, we must initiate treatment without delay. The first-line medication is almost always atropine. Atropine works by blocking the vagus nerve, which is a nerve that naturally slows the heart down. By blocking its action, atropine allows the heart rate to increase. The standard dose is 1 mg administered as a rapid IV push. We must be prepared to give this dose quickly, as the patient's condition can deteriorate rapidly. This initial dose can be a powerful and effective tool to jumpstart the heart back into a more normal rhythm and improve the patient's symptoms. After administering the first dose of atropine, we continuously reassess the patient. Did their heart rate increase? Did their blood pressure improve? Is their mental status clearing up? If the patient remains unstable and the bradycardia persists, we can repeat the 1 mg dose of atropine every 3 to 5 minutes. However, it is important to know the maximum total dose, which is 3 mg. Giving more than this amount is unlikely to be effective and could cause other problems. While waiting to see the effects of atropine, we should simultaneously prepare for the next steps in case it doesn't work. If atropine fails to stabilize the patient, or if they are so unstable that we cannot wait, we must move to more advanced therapies. The next option is often transcutaneous pacing. This involves placing large electrode pads on the patient's chest and back, which are connected to an external defibrillator or monitor. This device can send small, timed electrical impulses through the skin to the heart muscle, forcing it to beat at a rate we select. While it can be life-saving, it is also uncomfortable for the patient, so providing sedation or pain medication beforehand is important if the patient is conscious. Alternatively, we can start a continuous IV infusion of medications like dopamine or epinephrine. These powerful drugs, known as catecholamines, stimulate the heart directly, increasing both its rate and the force of its contractions. A dopamine infusion is typically started at a rate of 5 to 20 micrograms per kilogram per minute, while an epinephrine infusion is started at 2 to 10 micrograms per minute. These infusions require careful titration and constant monitoring of the patient's blood pressure and heart rate. They serve as a bridge, maintaining stability while we address the underlying cause or arrange for more definitive care, like a permanent pacemaker. While our standard approach covers many situations, we must also be aware of special circumstances where the treatment for bradycardia needs to be modified. For example, in the case of a suspected drug overdose, particularly from substances like calcium channel blockers or beta blockers, atropine may be less effective. In these scenarios, other treatments such as glucagon, high-dose insulin, or calcium chloride might be necessary to counteract the effects of the drug. Similarly, if we suspect high potassium levels or hyperkalemia as the cause, administering calcium and sodium bicarbonate is the priority to stabilize the heart cell membranes before trying to increase the rate. Athletes represent another unique group. As mentioned, a very slow heart rate can be completely normal for them due to their high level of conditioning. It is especially important not to rush to treat the number on the monitor for an athlete. If they are awake, alert, and have no symptoms of instability, the best course of action is simply to observe and monitor. Intervening with medications like atropine could be unnecessary and potentially cause an overly rapid heart rate. The guiding principle remains the same: treat the patient and their symptoms, not the EKG strip or the heart rate alone, and always consider the context. Pediatric bradycardia is a particularly ominous sign and must be treated with the utmost seriousness. Unlike adults, where bradycardia is often a primary electrical problem with the heart, in children, it is almost always a secondary event. It is typically the result of profound hypoxia, or a lack of oxygen. This means the child's body is in severe distress, and the slowing heart is a late and critical sign of impending cardiac arrest. The most common causes are respiratory failure or shock. Therefore, our immediate focus must be on reversing the underlying cause, which is usually related to breathing. The first and most important step in treating a child with bradycardia is to manage their airway and provide effective ventilation with 100% oxygen. In many cases, simply restoring adequate oxygenation will cause the child's heart rate to recover on its own. If the heart rate remains below 60 beats per minute despite effective oxygenation and ventilation, and the child has signs of poor perfusion, we must begin chest compressions immediately. For children, a heart rate below 60 with poor perfusion is the trigger for CPR. Medications like epinephrine may be given, but they are secondary to the critical tasks of oxygenation and high-quality compressions. In summary, managing bradycardia effectively hinges on a few core principles. The most important is to differentiate between a stable and an unstable patient. Remember, we treat symptoms, not just the slow number on the monitor. If the patient is alert, has good blood pressure and feels fine, observation may be all that is needed. However, if they show any signs of instability, low blood pressure, altered mental status, chest pain or shock, we must act quickly and decisively. This clear distinction guides our entire course of action and prevents both unnecessary interventions and dangerous delays in care. For an unstable adult, the treatment pathway is clear and sequential. We begin with the fundamentals: ensure a clear airway, provide oxygen, and establish IV access and monitoring. The first-line medication is atropine. If that is not effective, we must be prepared to start transcutaneous pacing or an infusion of dopamine or epinephrine to support the heart rate and blood pressure. Throughout this process, continuous reassessment is key. We must constantly check if our treatments are working and be ready to escalate care if the patient does not improve, always documenting our findings and interventions. In the pediatric population, the message is even more urgent. Bradycardia often signals severe hypoxia and impending cardiac arrest. The immediate priority is not medication but aggressive airway management and ventilation with high-flow oxygen. If the child's heart rate does not improve and remains below 60 with poor perfusion, high-quality chest compressions must be started without hesitation. This focus on oxygenation and circulation is paramount to saving a child's life. It is a fundamentally different approach than the one used for adults and requires rapid recognition of respiratory distress as the likely culprit. Ultimately, a slow heart rate can be anything from a sign of peak physical fitness to a harbinger of cardiac collapse. The ability to tell the difference and respond appropriately is a critical skill. By focusing on the patient's symptoms, performing a rapid assessment, and initiating a step-by-step treatment plan, we can effectively manage this condition. Whether it's administering atropine to an adult or providing life-saving oxygen to a child, a quick response based on careful evaluation can make all the difference, preventing a crisis and steering the patient toward a positive outcome.